Ladies and gentlemen, thank you for standing by, and welcome to the Disability Competent Care Webinar Roundtable Series. At this time, all participants are in listen-only mode. Later, we will conduct a question-and-answer session. Instructions will be given at that time. If you should require assistance during the call, please press star, then 0. I would now like to turn the call over to your host, Chris Duff. Please go ahead.
Thank you, Roseanne. Appreciate the introduction. On behalf of the Lewin Group, I would like to welcome everyone to this last of our current webinar roundtable series, this one focusing on integrating behavioral health services with primary care practice. As Roseanne stated, my name is Chris Duff, and I'm a disability policy and practice consultant. Under contract with the Medicare and Medicaid Coordination Office at the Centers for Medicare and Medicaid Services, the Lewin Group has engaged myself and a few colleagues to provide technical assistance to providers working with adults with disabilities. First, I'd like to introduce you all to the platform for this presentation. If your slides are not advancing, please push F5 on your computer keyboard. Also, please note the two icons circled at the bottom of the screen. The green one on the file folder, the green one of a file folder on the right provides you with access to resources for this presentation. The center icon with the CC will enable closed captioning, and the brown icon fourth from left will open a chat window for participants to pose and discuss any topic-related questions to other participants and ultimately to the speakers. After the brief presentation, we will also open the phone lines for participants to ask questions directly to the presenters. As stated earlier, this is the 8th and last webinar in this roundtable session. Last year, we published a comprehensive disability competent care self-assessment tool describing disability competent care in 3 key components: individualized care coordination provided by an interdisciplinary team, redesigned primary care delivery, and flexible long-term services and supports. We followed this up with 9 webinars this year focusing on individual components of disability competent care. All the webinars have been recorded and are available along with a PDF of the slides at the link at the bottom of this slide. Our goal in this series has been to be highly practical, using experts in each topic area with organizational examples or first-person stories to demonstrate key messages. The presentations are no more than 30 minutes, allowing the remainder of time to explore questions or issues submitted by the participants. The chat feature is available to participants throughout the webinar. Beyond the chat feature, to which you can submit questions and comments at any time, the open phone line will be available later. We will also be using an instant polling process to ask specific questions to guide our presentation. To demonstrate this process, here is the first polling question for today. At present, are you working within a health plan, a behavioral health provider organization, a primary care provider organization, a combination of the above, or other? If you could make your choice and submit, we will all see a tabulation of the answers shortly. Today we're exploring the issue of how to address both physical and behavioral health needs of adults with disabilities in an integrated manner. I will say that my professional experience leading a pioneering disability competent care organization is that we never did this very well. In fact, I know that most of my peers in other pioneering organizations also felt they never had their hands around this issue very well. In reflection, I believe it came from not understanding the preponderance and impact of behavioral health issues experienced by our participants. I remember vividly asking about this issue once at one of our monthly member meetings, and one person spoke up saying simply, "Look at us. Wouldn't you be anxious and angry if you dealt with the barriers we experience every day?" I think that speaks to the experience of living with a disability, though it doesn't even reflect the chemical imbalances that are the foundation of bipolar illness, chemical dependency, and psychosis. This historically siloed approach to addressing the physical and behavioral health needs of adults with disabilities is also based on services being managed or funded by different systems and organizations. For example, many private insurers, as well as some state Medicaid programs, have historically carved out behavioral health services to be managed by behavioral health systems or networks. As the speakers will demonstrate, there is no magic approach to integrated care and support. For every approach has its barriers and challenges and needs to be treated as a work in progress. This is perhaps one of the greatest systemic challenges and opportunities being faced as our healthcare delivery system is reformed. Our goal today is to learn from one set of providers within one setting in one community. It is thus our individual responsibilities to glean the learning from their experience and bring this to our own setting, our own systems, and most importantly, the participants we serve. At this point, let's go back and review the first polling results. I see that most of you were operating within a health plan. Very few behavioral health organizations are at the table yet. That's quite interesting. Very few just primary care. Some of you are a combination of both, and most of you are other. And my guess is most of the other are home community-based, or what last week we referred to as community-based organizations, AAAs or government. So I think clearly what we're speaking to is primarily health plans, and really don't have that many on the direct healthcare provider side. So that gives us a bit of a foundation to the speakers as they move forward here. Before introducing the speakers, let me pose the second polling question that will guide us a little further. The question is, are you familiar with issues and challenges of understanding and integrating physical and behavioral health needs of persons with disabilities? Please choose one of those answers, and after I introduce the speakers, they will review the results. Today's webinar will be presented by Cindy Goodall. She holds a master's in social work and is a licensed independent social worker, certified psychiatric rehabilitation professional, and a certified brain injury specialist. She has over 20 years' experience in providing community-based services to individuals with various disabilities, including mental health disabilities. Cindy is the manager for community services at Courage Kenny Rehabilitation Institute in Minneapolis, Minnesota. Cindy has presented regionally and nationally on the topics of brain injury, mental illness, and community integration for individuals with moderate to severe disabilities. She will be joined today by Dr. Brian Gould, a board-certified psychiatrist with a long interest in psychopharmacology and the psychiatric treatment of severe neurological disabilities. He early on became a recognized expert in the psychological aspects of ALS, or Lou Gehrig's disease. He has served as corporate medical director of Blue Cross of California and was subsequently a senior executive of United Health Corp. About 15 years ago, he left United and has since headed up a variety of innovative projects in international healthcare and healthcare information technology, and developed a telepsychiatry product. Since 2010, Dr. Gould has resumed his clinical practice as a psychiatric consultant to the Courage Kenny Rehabilitation Institute. Now, I'll hand it over to Cindy to review the first polling question after her presentation, and she will pull in Dr. Gould for questions and comments. Cindy.
Thanks, Chris. I appreciate the introduction. Could you advance the slide, please? So here is the answers for the second polling question. Are you familiar with the issues and challenges of understanding and integrating the physical and behavioral health needs? And highly familiar, 16.1. Most of you feel like you're moderately familiar, and then some minimally familiar. So we're in good company. So we can go to the next slide. First of all, I wanted to talk about the prevalence of behavioral health disorders in the Medicare, Medicaid, dual eligible population. About 40% have a mental health disorder in the under 65 population. So it's a very prevalent condition, and that's the people who are diagnosed. And then also that population has higher rates of substance abuse and comorbidity of 3 or more chronic conditions. The dual spending for folks with serious mental illness is twice that of the general Medicare population. So I think, as Chris had mentioned, one of the challenges with our Medicare and Medicaid system of providing services for these individuals is that the care is oftentimes fragmented. Medicare pays for the acute care, either physical or mental health services and care, while Medicaid is the system that pays for things like psychiatric rehabilitation or long-term services and supports. And so there are two different funding streams supporting this person and their health care needs. In addition, many of states have carved out their behavioral health services out of their managed care products, even if it's been an integrated product for both Medicare and Medicaid. Often, some states, a lot of the mental health services are in sort of standalone kinds of clinics and community resources. We can go to the next slide. How the system has approached integrating care has happened in some different models for clinics. The more traditional model is a collaborative model where the primary care provider would make referrals to a behavioral health care provider. The person goes to two different places to get that care. There might be some communication back and forth, but it's still very separate. A more common or kind of a model that's becoming more and more common is the co-location of primary care and behavioral health care clinics. That can be either primary care within a behavioral health care clinic or behavioral health within a primary care clinic. And those can, the benefit of those is that seeing a behavioral health provider becomes like seeing any of their other medical providers. It's not, they don't have to go to a separate place that they're not familiar with or that they may have some stigma about going to. In addition, the primary care within the behavioral health care is oftentimes used for folks who have serious and persistent mental illness and where their main access to medical care has been in the behavioral health world. And then the more integrated model with oftentimes seen in in a healthcare home sort of a setting where it is primary care and behavioral health care teams are integrated and assigned to a panel of participants. As we have talked about in the other sessions in this roundtable series, the disability competent care team model is another model that involves a primary care practitioner, behavioral health professional, nursing, and the long-term services and supports. And as we'll talk about in a few slides, the Advanced Primary Care Clinic here at Courage County Rehabilitation Institute does follow this and have all the components within the disability competent care model. Another kind of area of disparity or sort of system clashes for people with both behavioral health care needs and physical health care needs come from the different models of care that they might encounter. One, the more traditional medical model where a person has an illness, it's diagnosed, it's treated, it's done, and the providers are the experts and the people sort of in charge of that interaction. A more person-centered model, which comes from the independent living movement, focuses on the individual's own goals and priorities, and with the ultimate goal of social and community participation as the end result of the care that they receive. It's looking at what's important for the person, but also what's important to the person, and using that what's important to the person to affect what's important for the person, like their healthcare needs. The third model is the recovery model that comes from the behavioral health care world for individuals with either mental illness and or substance abuse. And it's the process of change through which individuals who have behavioral health needs are able to live a self-directed life and strive to reach their full potential. And it can include 4 different dimensions. And as you can see, those dimensions include the things that we all would agree lead to a meaningful life in the community, and that's to have health, to have a home, to have some purpose, and to have a sense of community and connection to others. Recovery is, for a person with a behavioral health condition, recovery is often nonlinear. It doesn't just go, it's not a process of continual growth, well, it is a process of continued growth and improvement, but it may involve some setbacks in functioning. So at times, a person with a behavioral health condition might need a lot of support and need a lot of direction and have a lot of difficulty in their functioning. And at other times, they can be doing quite well and want to be as independent and involved as process in their care and as self-directed as they can be. So, and this, I think, differs quite a bit from when I think about serving individuals with a disability with behavioral health needs and comparing that to serving like an elderly population. I know there's a lot of folks here on the call from the AAAs. You know, oftentimes with an elderly person, once they start to need some support and assistance, there is a caregiver or a paid support person who becomes involved and sort of stays involved with that person sort of for the long term. Whereas with people with disabilities or with behavioral health needs, since their functioning can go up and down, at times that support might be involved or they might not be involved depending on what the person wants or is needing at that moment in time. And so I think sometimes that can be difficult for the medical field or other providers to understand that now they don't need a support person or now they do need a support person, and to kind of work with them with wherever they're at. Thank you. So I wanted to talk a little bit about our advanced primary care clinic here at Courage County Rehabilitation Institute. It is certified as a healthcare home. We're in Minnesota, so our healthcare homes are certified, and we started in January of 2010. We're currently serving a pretty small patient panel of 200 folks, and we have staffed with physicians, both primary care and psychiatry. Dr. Gould is serves patients in the healthcare home and then also in the psychiatric practice. We have our system is mostly with nurse practitioners with a primary care physician as the lead. And then we have nurse and social work care coordinators and certified medical assistants. Our practice is co-located with physiatrists who deal with the medical rehab needs of our patients. Our clinic is very physically accessible, and then we have developed clinical pathways for the most avoidable causes of hospitalizations for our patient population, which includes urinary tract infections and seizures and diabetes. So, and as you can see, one of the really neat things about our clinic is that we provide quite a bit of time for our patient visits, with an hour scheduled for an initial visit and then with an hour follow-up phone call or meeting with the care coordinator or social worker after that visit to gather additional information. We also have a telemedicine option, which is a very exciting option that we've been able to develop, and that is where we can provide services over a phone connection and a computer connection. Actually, it's a service similar to a Skype kind of thing, where we actually have volunteers who go out with the computers to people's homes and then help facilitate that visit. And that really provides a nice bridge for folks who have mobility issues with getting into the clinic, either mobility or behavioral health issues with coming into the clinic. I do also want to mention that we were the recipient of the Innovation Award through CMS in 2012, and so we are under a 3-year grant with that award, and that's what's allowing us to offer things like the telemedicine and having the extended appointment times and things like that. So the approach within our advanced primary care clinic is person-centered and recovery-oriented, working with clients to set goals that are meaningful to them and addressing their health needs within the context of their goals, honoring the client's preparation for their meetings and the strategies that they've worked on in their rehab or with their long-term services and supports to increase their functioning and to compensate for deficits. And then it is really focused on the social participation that their health allows versus health just for its own sake. So then wanted to share with you a story of a person that we've served, and that is Karen. And Chris, could you help me out here? Have people seen the story, or should I recap the story for them?
If you would recap it, that'd be great.
Thank you. Sorry about that. So Karen is a 45-year-old woman who has cerebral palsy and a mental health diagnosis of major depressive disorder, anxiety disorder, and a personality disorder. She has numerous services through Courage County Rehabilitation Institute, including the advanced primary care, some rehabilitation, psychiatry, fitness services, and our psychiatric rehabilitation program. She also receives waivered services, including supportive housing and employment programs. About a year ago, she was diagnosed with type 2 diabetes, and while this was a relatively routine diagnosis from the primary care perspective, it was very devastating for her. She kind of lives on a thin margin of coping and having something else to deal with and to have to make changes for was very confusing for her, was very frustrating, and resulted in sort of an extreme emotional response to the news, where she at first was refusing to cooperate and refusing to believe in the diagnosis or to cooperate with her changes that she needed to make. The care coordinators in the clinic were able to take a multi-pronged approach for her to help her cope with this new chronic condition, and psychiatry evaluated her for her medications and mental health in adjusting to this. And then they partnered with our psychiatric rehab staff to work with her on some motivational interviewing techniques to sort of come to terms with her diagnosis and identify some changes that she felt ready to make and get her to the place where she was able to make those changes. The care coordinators also worked with her one-on-one to address her concerns and provide feedback and monitoring, as well as worked with the housing support provider about the dietary changes. Since she's been diagnosed about a year ago, she has been able to make the change of stopping regular soda, and then is now monitoring her blood sugar at least once a day, if not more, and her mental health has stabilized with some medication intervention. So I think we can go to the next slide. So the results that we've been able to see within our advanced primary care clinic include an improved participant perception of health as measured through Healthy Days and the patient activation measure, decreased symptoms of depression as measured by the PHQ-9, reduced hospital days per person, and a better experience of care for the people that we serve. Okay, we can go to the next slide. Some of the challenges that we've seen within our primary care clinic is gathering information about the long-term care services and supports that people receive so that the primary care clinic and the care coordinators can help leverage those for the people that we serve, in addition to the mental health, more longer-term or psychiatric rehab type services. Oftentimes when people were coming into the clinic, they weren't able to kind of say who all of their providers were in their community, who all their supports were, what their names were, what the phone numbers, so that there could even be releases of information signed. So just gathering all of that information was oftentimes very challenging for the care coordinators and took quite a bit of time. In addition, that also kind of brought up some data privacy concerns in that in order to be able to coordinate with these long-term care services or psychiatric rehab services, a release of information needed to be signed if they weren't part of our system. And you need to know what the agency is that's providing the services in order to do the release of information. And those releases needed to get signed up front when the person was first accessing care, so that as problems or challenges came along for them, the coordinators were able to leverage those supports in the community. And so I think that's kind of an ongoing challenge that we continue to have and are trying to have workarounds. One of the other challenges that we see in the clinic is the impact of the social determinants of health. Oftentimes the people that we serve within our primary care clinic have had a devastating illness or injury. We're a rehabilitation provider, so often people have had a stroke or a brain injury or a spinal cord injury and then have accompanying mental health concerns on top of that, some in relation to the adjustment, but then maybe they had some mental health challenges before also. But with this new diagnosis and new disability, they kind of are plunged into poverty. Obviously, we're talking about duals. They're they're on Medicaid, where perhaps before their illness or injury they worked a full-time job and had private insurance and had a lot more financial resources. And so in addition to their functional limitations, they're also learning to live in poverty and kind of adjusting to life that way. And that kind of brings up all other kinds of difficulties in terms of accessing their health care and providing for their health care in terms of being able to afford their medications or getting to pick up their medications, accessing resources in the community, just understanding how the system works. I think for a lot of people that's just really a big challenge, and they don't know where to start, and the care coordinators try to walk them through, but it can be a somewhat complicated system. In addition to people who are duals, even the folks who aren't yet on Medicaid but are on Medicare and are near poor also have a lot of challenges with accessing community resources if they can't get on Medicaid because of spend-down issues. And then another challenge that we've seen is, and this is just something that the providers have to keep in mind all the time, is just redirecting the care to a more person-centered recovery-based approach versus the familiar medical model, and using the language and the goals that the person is able to identify themselves to sort of structure their other healthcare goals. We can go to the next. So the other, so kind of some lessons that we've learned within our advanced primary care clinic is the importance of partnering with the participant and their support network. We found that by doing that, we're able to get to better results, and the person is able to have a more lasting change for their behavior change if their support network can also be reinforcing that with them, as well as getting the participant on board in terms of making those kinds of changes or being active in their own health care. The social determinants of health can't be stressed enough at how devastating sometimes these illnesses and injuries can be for the person, and how their life has been turned upside down. And for them, the recovery hope is that they can get back to a life that's meaningful to them. Communication is the key between the primary care clinic and the long-term services and supports, as well as the mental health providers like the psychiatric rehab or the therapist or psychiatry when they're involved. And the participant often can't be that communication link, but there can be some tools that we've used either like with communication books and communication logs that the patient can bring with them, or communicating by phone or email, those types of things. One of the challenges is, we're getting into an electronic health record, but these long-term services and supports, and even some of the mental health services aren't necessarily on electronic health records, and so it really makes the communication piece challenging. Developing care pathways have had great results in terms of reducing hospitalizations and emergency department visits. And then we've really had some great success using the motivational interviewing approach for people who have behavioral health conditions, but also people who don't necessarily have behavioral health conditions but who need to make behavior change. And that's a long process. It doesn't happen overnight. Motivational interviewing is a long takes quite a bit of time with people, and so, but it really can have some great results when it's done. Dr. Gould, did you want to make some comments about the lessons that we've learned in terms of working with this population?
Well, thank you, Cindy. Are we done or?
Yeah. Oh, is there another slide? I think it's the.
Well, that overview is excellent, and it nicely describes what we've tried to do. I'm always very nervous about generalizations, both because to the extent to which we talk about our population as being disabled, we erase differences between the experience of a traumatic brain injury versus a spinal cord injury versus growing up and living one's life with cerebral palsy. They're not at all the same. The types of conditions that we're confronted with are different. And yet, at the same time, we see a recurrence of some types of issues regarding disability and dependency, changes in financial status, socioeconomic status, impact on marital and family relationships, that where we do feel we develop some expertise. Our staff in the last few years has been very excited about the advances made in funding and awareness of the need for an integrated, person-centered model rather than the traditional specialty-oriented medical model. We find we can do more better if we work together. But I've also found that there's some fear and anxiety on the part of the staff with that as well. Patients can get confused about who their doctor is. Staff can get worried about, while we're integrating things, who's backing me up? What happens if I get overwhelmed by a patient's needs and so on? So we find we're making progress with it in the way you've described, but it's slow going, it's difficult work, and we think that our experience has something to teach other programs that don't see as many of the dual eligible disabled patients as we do, but we're not yet taking any victory laps. We feel humbled every day by the patients we have to deal with. Your vignette, for example, of Karen, you ended on a very optimistic note about how much better she's doing, and in some ways she is. What you don't know is last week she was hospitalized overnight in a suicidal crisis because her parents, who are her custodians, would not let her send money to an internet suitor who said he loved her and wanted to come visit her, and she was going to send him the money. And when she couldn't do that, she got so frustrated that she started talking about killing herself and was hospitalized overnight.
Well, I think that's the nonlinear part of mental health recovery is that people oftentimes have setbacks and life comes at you and new frustrations and new challenges, and so.
Oh, she's going to learn a lot from this.
But
We're going to make sure she learns a lot from this because it's a very adolescent kind of crisis that she's navigating in her 30s, but that's part of the consequence of her disabilities. She is maturationally retarded, but that doesn't mean that she doesn't have the same desires and needs as any other person.
Thank you, both Cindy and Dr. Gould. I appreciate it. I think that last example that you talked about was great. I'd like to do a follow-up on that example itself. Dr. Gould, so she was in the hospital last week. Sounds like she was there for 24 hours. How first of all, were you aware of it while she was in the hospital? And secondly, how did you facilitate the transition back into the community and the care system that had been built to support her?
Well, unfortunately, I wasn't aware of it. She came to clinic that day, met with her care coordinator, who immediately came and spoke to me about this plan to send money, and that was our first awareness that this long-distance relationship was even going on. While we were conversing with that, Karen had returned back to her assisted living facility and was talking to her parents, and the suicidal crisis emerged from that. We weren't involved in it. The county emergency services was called. They did an evaluation, and she went to a hospital that wasn't ours. So I didn't hear about this until she was being discharged, and we were contacted in a very appropriate and helpful way, but after the fact, and we're following up on the hospitalization. But it took place outside of our awareness.
Doctor, first of all, I'm very sorry for her sake that it unfolded in that way, but it's a great learning for all of us, and that is exactly how it happens. While you're talking in the clinic, but what do we do now? She's going to her assisted living setting, talking to parents, she's becoming suicidal, and before you know it, she ends up being taken to a different hospital, and you, as the primary team with her, weren't aware of it until the next day. That we've all seen that happen and will continue to happen.
The county, by the way, did a beautiful job in assessing a complicated case, making the right intervention. I even called the social worker and the doctor and complimented them. They, although it was not ideal because we weren't involved, but everybody worked really hard and did a beautiful job for her.
I'm glad to hear that, and I think this is a great, I mean, Minnesota, Minneapolis, St. Paul have a great, I mean, for the most part, it's a great coordinated system. And so I'm glad to hear you did follow up. When you look back on this, is there something that you would like to have happen differently the next time she comes upon a suitor?
I think we underestimated her immaturity and her distress. I don't think this was depression, and at least not clinical depression, but situationally she overreacted, and she overreacted in the way that a teenager might. And as I say, because of her age and our familiarity with her, I think we underestimated that.
I really appreciate you're willing to share. Not all care situations are successes, but to be able to step back and look at it and what can you do? I really appreciate it, because that's the fact that she was only inpatient for 24 hours and she went back to where she was is a win. And the fact that she got reconnected back to you guys is also a win.
Yeah, it screws up our statistics, of course, but, what are you going to do?
That's a bit of the problem. When you are a pioneer, you end up with situations like that. And you're sharing them with all of us helps us with that. What I'm going to do another at this point, let's open up the phone line. So, Roseanne, could you do the introduction? Roseanne?
Sorry about that. I had to get my mute button open. Ladies and gentlemen, if you wish to ask a question, please press star then 0 on your touch-tone phone. An operator will answer your line, gather your name, and give you further instructions on how to queue up to ask a question. Once again, if you have a question, please press star 0 so you can give your name to an operator. And it'll just be a minute for somebody.
Great. I think I'll proceed with taking some of the questions we've been getting online. One question from Marilyn at Access Living is the recovery model and the person-centered model both emphasize self-direction and respect for the person's decisions and choices. Can you clarify the distinctions between these two models? Are they contradictory? Are they complementary? And how are they different? And are there issues with that?
Well, I can take that one, Chris. Thank you, Marilyn, for the question. And I've read where the recovery model is a person-centered model, so I would say that they are very complementary. The difference is the recovery model really focuses on the sort of the journey that a person with a behavioral health disorder goes through in terms of their and the emphasis that they have on their hope for recovery, and then that's what's motivating to them and kind of drives their experience, and that they're looking for providers who have that same hope for recovery. And so they are very complementary, and the recovery model is just more of a behavioral health focus, and the person-centered model is kind of comes more from the independent living movement, people with disabilities in general, and wanting to understand the person's own goals and priorities.
The other thing that struck me as you were talking about the first time round, you referred to the other models, both the medical model as well as independent living in many ways, as being fairly linear, and that makes sense to me. But you said the recovery model, and when I think of recovery model, I tend to think of the chemical dependency where you're always in recovery.
Yep.
And so you say it's not necessarily linear, and that was a learning for me. Can you talk a bit about how do you, as people kind of are places and you put some systems in place and they're doing well, how do you begin pulling back some of the services that's doing well? How do you know when to come back in to give more services when they're in a crisis or an issue? In other words, how do you manage in a non-linear situation?
Well, and that's the trick of it all, isn't it, Chris? And it's, the thing is that when a person's in mental health recovery or even with substance abuse, they need a lot of support when they're in this time of crisis or when their functioning is lessened because of the symptoms of their mental illness. And so as they start to increase their functioning, it's important to provide them with opportunities to regain their skills and to practice those skills and to work with them kind of where they're at. And so if somebody, when they need more support and they have a support caregiver with them, then that's great and that's easy for the provider, I think sometimes, is to have that caregiver there. But then that caregiver, if they're trying to teach them to be more independent, they're going to start backing off and they're going to start giving them tools to maybe advocate for themselves or to take notes at their meetings or to prepare for their meetings ahead of time. And that's going to take a lot more time on the part of the provider to honor that and to honor that person's preparation and their skill building. It's going to, again, take more time. It might be easier just to have that support person doing things for them, but it's important for that person in their recovery to regain those skills and regain that confidence that they can take action for their own healthcare needs. So then on the flip side of when do you kind of add in more supports or try to involve more supports when the person isn't doing as well is also the trick of it all. I mean, that's kind of the situation with Karen where, she's talking about a crisis to her that's going on in her life, and, and sometimes that we misjudge that. We think, this isn't that big of a crisis where it's really going to take this big intervention, but sometimes it is. And we just do the best that we can and listen to the person and what they're saying and where they're at and observe. And so hopefully with a longer-term relationship, we can get to know them and to work with them within that relationship.
Thank you. I think that there's two components that you mentioned. One is within the relationship, and that's something we talked about every step of the way through these webinars, that care coordination only happens within a relationship.
Right.
You certainly brought that forward. And secondly is that's the art of being the care coordinator versus the science. And I think that's something that individuals have to find their way with.
Right.
I want to go back to Dr. Gould for just a minute. Dr. Gould, we on slide 8, Jesse, if you could go to slide 8. Just 1 second here. Please excuse me. On slide 8, we talk about the clinic models: collaboration, co-location, and integration. Where would you describe where you guys are now, and are you happy with that? And if not, where are you trying to go to, and how are you going to get there?
Yeah, from the inception of the healthcare home, we've had co-location of our primary care and our behavioral health services personnel. We are attempting to grow up into an integrated model. We're not exactly sure what that's going to mean with our population and exactly how to do it, but goodness knows we're trying. As I alluded to earlier, I found a little bit of resistance from some of my colleagues. Now, everybody, talking about integration is like talking about fairness and equitability and self-actualization. Who's against it, But when we've started to talk about programs where I wouldn't do a traditional consultation on a patient, they would stay in your practice and I'd be a consultant to you. I noticed that the other providers would at times get a little bit edgy about it and say, well, you mean I can't refer to you anymore? What am I going to do with a patient who needs a psychiatrist? Aren't you taking any more referrals? So, no. It's going to be better, believe me. And what I hadn't fully appreciated until this came up a few times is that what I was looking at as a step forward into integrated care, the primary care providers were nervous as a euphemistic way of saying they weren't going to be able to get psychiatric consultations anymore. And I can see that. That's not what was intended, but it reinforced to me that with all of the high concept about integration and the technology of video conferencing and so on and so forth, there's still some value in the traditional model that we don't want to lose. These are difficult cases that can be overwhelming. Our patients need so much medically, psychologically, financially, socially, that to remove people, if the integrated model means the person who's on point is more alone, it's not going to work. They've got to have a lot of support, and we have to be very clear about who does what. So it's a long-winded way, Chris, of saying I think we're in transition. We're trying to develop the integrated model because we all agree that we want to have as comprehensive and person-oriented approach as possible. But we're taking it one step at a time and doing it very carefully.
Thank you. I think some of what you just talked about is a real practical application of how you evolve a system. We have a question here that's very much along the lines from Cynthia at LA Care Health Plan. I think, Brian, you might be familiar with them, having worked in Southern California. How did you gain acceptance from primary care physicians who may see some of these people in the community? Or maybe, Cindy, I know you see people who aren't necessarily, or your staff see people who aren't necessarily at the Courage Kenny Clinic. So how do you get them engaged?
Well, our psychiatric rehabilitation services, we call it ARMS in Minnesota, but that service we work with clients who have providers that aren't necessarily at Courage Kenny, that are at different practices, and that's where where we've seen things work well for the person that we serve, and not so well, where physicians might get somewhat impatient with the client for practicing their skills versus just having a support person come to appointments with them, or the client will come prepared with their list of questions and the provider doesn't always honor them. And I think a lot of that has to do with the time constraints that are built into into a lot of clinics, where they're trying to get through their patient load and don't have the time to spend to really meet that person where they're at, and to do that extra work of understanding their goals and their motivations and that type of thing. So, but I think for the doctors like in our clinic that have the experience of having that work really well, they've found they support it and continue to do it, and that is great for from the perspective of the person that they're serving.
Makes sense. I'll take one more question here. Marvin from HEOPS has asked, you mentioned the challenge of maintaining a person's HIPAA rights, and then how big a problem is this in regard to coordinating care? And how do you deal with that? How do you address that?
Well, certainly everybody has their rights to privacy, and nobody wants to violate their rights, and everybody honors that, but it makes care coordination really, really difficult, kind of working under those rules, especially when you're talking about a medical system communicating and coordinating with what would be considered non-medical providers, or providers that are outside of medical system, like the long-term services and supports, or that kind of thing, then a blanket consent that a person signs as they come into the clinic saying that you can talk to any other medical provider doesn't cover that. Wouldn't cover their supported living setting or their mental health supports necessarily. Some of them are considered medical services, some of them aren't, depending on kind of where they're at within the state's Medicaid plan. And so I think it just makes that care coordination really, really challenging, along with the fact that, a client has the right to make their own choices and to, sometimes to go off and go to a hospital that isn't part of our system, or, see some other providers, and all of that makes it kind of messy. So what we found is it's just important to have those conversations with patients up front about the need for releases of information and get those in the books right away, so that as the need arises, to have more of an active role in reaching out to people that wouldn't be covered under the existing consents, so that you're covered and can do your work as a care coordinator.
Makes sense. At this point, I'm going to stop for just a second and point out the resources we have nearing the end of our time here. We can go to slide number 24. There will be a list of resources, and a couple in particular, I think. First of all, there's some that just describe the models that we talked about before, the coordinated and the other end of the screen being integrated. There's a self-assessment tool that is really to help behavioral health programs in particular, but also primary care providers, kind of assess where are they on that continuum and how can they prepare, how can they move along on it. There's some further information about the mental health recovery model at the SAMHSA website that is on slide 24 that you will be seeing momentarily. And we'd also like you to note that some upcoming webinars, here's the slide to get some of those websites. There will be another series that will be coming up shortly that will be focused on consumer engagement, and we hope that you will participate in that. You'll be getting an email for that shortly. So before kind of going to the final closing, I'd like to ask a question around pharmacology. And perhaps Dr. Gould would be best with this. My experience is people who are treated in multiple systems, and I speak from my experience, people with physical disabilities who are treated like almost, oh, by the way, they have a mental illness, kind of on the side, so someone slaps some medication or two on. How much of how do you coordinate medications that are put on across providers and systems of care? Because I assume that when you take over working with someone, you look at their whole med list and kind of begin to get a sense of, okay, what's going on here? Are there some conflicts? Are there some issues? Are we addressing the right stuff? And how do you coordinate that across providers, both primary care as well as other specialty providers?
I have the good fortune to work in a system where there's a great deal of respect toward each other. And by that, I don't just mean at Courage Kenny, in the surrounding community of providers. I have found that when a patient is on a medication regimen and they're referred to me, the implication is I can change the psychotropics if, in my judgment, that's required. When a patient, for example, the Karen story, she was hospitalized overnight, but they didn't change her meds. They could have, and I've practiced in environments where they would have, like cats marking their territory. But here, they didn't, and they wouldn't. She came back to me on the same meds, and it just, that type of coordination has come very spontaneously and easily in this community.
That's great. That while we preach about the relationship with the consumers, and care coordination only occurs within a relationship with the participant. It also only occurs within a community of providers who do work and have relationships with each other. And so when the person's hospitalized in a different system, and I know exactly what it was, the fact that they knew, so-and-so's involved in this, we'll call him once we're ready to move back out. And so that they didn't take that person on per se. They got them through the crisis, but right away they knew that you were going to be picking that up, and they had confidence that you would, so they didn't have to worry about that. So I think that speaks to the importance of nurturing the relationships across your own health system as well as the community's health system. Well, at this point, I think I need to wrap this up. We've reached the end of the hour. As I stated, this is the last in our current webinar roundtable series. We've now completed 17 disability competent webinars. The Medicaid Medicare Coordinating Office, Lewin, and our team of disability consultants are very pleased with the continued and growing interest in these webinars. This has been shown by the attendance and growing numbers of downloads following these real-time live webinars. We hope that continues. These webinars are available for ongoing training and reference whenever any of you wish. Besides the series that I mentioned just briefly before, we'll be taking a bit of a hiatus in webinars to kind of regroup and reevaluate where we're at. Everyone who has signed up, well, first of all, may I reference that there's this online evaluation that we hope you'll complete for this webinar, and it's just a quick click on the link. It takes just a few minutes the most. But we will also be sending out a survey to everyone who has signed up for any of these 17 webinars over the last 8-9 months to get your ideas for the future. We certainly have no shortage of ideas. We want to make sure that the work we do going forward remains closely aligned with your individual needs and interests. Again, I would like to thank Cindy and Dr. Gould for your presentation today, and we look forward to continuing our work this year to support plans and providers in meeting the needs of people with disabilities. Thank you very much.
Ladies and gentlemen, that does conclude your conference for today. Thank you for your participation and for using AT&T Executive Teleconference. You may now disconnect.